Okay, we'll jump in. So I'm Fred Lado. I'm here representing the National Association of Epilepsy Centers. I'm also a full-time epileptologist clinician. That's actually my day job. I work at a comprehensive epilepsy center in Long Island, and we have sort of the full spectrum of services for adults, including epilepsy surgery and mental health services, etc. But in this role, I'm here to tell you a little bit about the NAEC, National Association of Epilepsy Centers. And the overview here is to just identify the services that are offered at epilepsy centers, to distinguish between level 3 and level 4 centers, a classification that the NAEC uses. Understand what role the NAEC has in accreditation and epilepsy care, and then just to kind of look forward into how we see the standards of care evolving over time and what we do to try to push that along. So we were founded in 1987 as a trade association, and now we're almost 260 specialized epilepsy programs, often mostly at academic centers, but we have some private centers, particularly some of the smaller ones in rural areas. Our mission is to support those centers delivering comprehensive care to individuals with epilepsy. We are a standard-setting organization. We advocate with insurance companies, with governmental agencies, and we provide knowledge and resources to our members to help them provide services. What distinguishes an epilepsy center? Most importantly, I think it's got a comprehensive team of caregivers, doctors, nurses, PAs, psychiatrists, psychologists, epilepsy surgeons, and as well as resources. Often there's, for instance, genetic counseling available in these centers, advanced testing techniques, either with EEG or other diagnostic imaging techniques, and some sensitivity to treating the comorbidities, the things that happen to people who also have seizures. So all of those are in the scope of what an epilepsy center should be addressing. From a patient's perspective, what's the advantage of going to an epilepsy center? Well, most of all, just expertise and experience in caring for epilepsy and the conditions that travel with it, expertise in using the diagnostic tests that are available, as well as diagnosis of rare genetic forms of epilepsy. Some therapies like ketogenic diet, or epilepsy surgery that don't involve medications, epilepsy centers specialize in, as well as a lot of education and becoming knowledgeable about epilepsy and what its different effects are. And then, of course, clinical trials are often based out of these academic centers, and epilepsy programs will give patients access to whatever the newest investigational drugs are. We've established 2 levels of center care, level 3 centers. They sort of provide the basic range of specialized services, obviously epilepsy expertise, neuropsychological testing, social services. But then level 4 centers do all of that, but also provide advanced diagnostic testing like intracranial EEG, epilepsy surgery of different kinds, some advanced methodologies, in some cases like laser ablation techniques. So the NAEC is in the business of accrediting each of these. We've got also 2 different demographic groups that we serve. Adult centers serve patients over the age of 18. Pediatric centers serve patients under the age of 18, and we've progressively raised the standards. There, we require evidence that they're able to treat and take care of patients under the age of 2, for example. And we used to have a category of adult and pediatric centers. That's being phased out this year because we felt that it allowed centers to meet the standards with one or the other group. Maybe they had a great adult epilepsy surgery program and they came in as level 4, but they didn't have a pediatric epilepsy surgery program. And so we felt from a patient's point of view, it's clear if it's describing the pediatric or the adult program separately. Then this process of creating standards and guidelines is one that has been evolving. In 2013, the Institute of Medicine said hey, epilepsy community, you really should be doing accreditation the way we do in other conditions, stroke perhaps most importantly. And that means that hospitals who are accredited have met and have shown that they can meet certain standards. And so the NAEC took that to heart, developed an accreditation program, started rolling that out in 2016. And this is just a sort of a snapshot, a high-level view of the things that we ask centers to document, what kind of services they provide, the volume of services, type of personnel that they have, and the use of safety protocols to guide care and make sure that patients are receiving appropriate management. Currently, we have about 254 centers. Most of those are level 4, the ones that do surgery. About 20% of them are level 3, that are basically medical care, non-surgical care. They're split more or less evenly between adult and pediatric, once you take out the adult-pediatric blend. You'll see that pediatric number go up. And they're mostly throughout the United States, but you can see in this color graph that Texas, California, Florida, and New York each are overrepresented with a number of centers. A lot of states have at least one or 2 centers, and then there's a handful of states that don't have any, and particularly in the upper Midwest and West, Montana, North Dakota, South Dakota, is a gap. And as individuals from those states know, the distance between locations, having a center in Idaho when you're on the other side of Montana, these are tremendous distances patients have to travel to get care. So that maybe frames one of the issues that comes up, which is why don't we put the standards really way up here, because we don't want to discourage centers from North Dakota getting started and building their expertise in providing service where there is none. So we have standards that hopefully are bring the whole community of epilepsy providers along and don't separate it into centers that have the most resources and centers that just can't bring that level of resource to bear. If you want to find a center near you, you can look at the NAEC website, and there you can put in your zip code or look under your state, and it will give you a list of all the currently accredited centers. So a couple more words about the guideline history. This process of writing guidelines started shortly after the NAEC started work, and 1990 was the first one, and we've had roughly every 10 years an update. We just did the last update, and that was a different approach. We had a much broader group of stakeholders. About 10 to 15% of the group was patients or patient advocates, as well as a much broader representation of caregivers. We had EEG technologists, neuropsychologists, in addition to epileptologists and epilepsy surgeons. And we came up with over 50 guideline recommendations. The most important changes is, whereas before, guidelines really focused on inpatient care, what happened in the epilepsy monitoring unit, what happened with epilepsy surgery, the new guidelines have a much larger orientation towards outpatient care. Still a lot on the old stuff, on the inpatient and surgery guidelines, but much more than we ever said before about outpatient care. And I think that will be a direction that we continue to move in. This is just one more step along an evolution of the guidelines. One of the reasons I'm here today is hopefully to engage with patient groups and to really welcome some of that feedback to really help shape how we take the guidelines as they continue to evolve. So the questions I'll leave you with here then are really questions for the broader community, which is, are there areas that we should be creating criteria that would benefit rare epilepsies, for example, such as genetic testing criteria? We do have, one of our guidelines does address genetic testing, but it's a first step. I think much more could be said. Counseling clinics, nutrition, diet, other things. Should we ever accredit centers based on their ability to serve specific types of patients? the different genetic types of epilepsy that are being discovered now. Should we create more resources for allowing patients to find centers that have particular expertise in one particular genetic epilepsy? And then more broadly, most broadly perhaps, what should NAEC be doing that we're not doing that you think is important, that we should be thinking about? And so with that, I'll sort of leave the rest of the time for questions or discussion.
How frequently does NAEC do their credentialing?
So we have, centers are on a 2-year cycle. So if you do full credentialing, you're pretty much good for 2 years unless you have some kind of big change that is one of our core criteria. If, for instance, you lose your epileptologist or your epilepsy surgeon, that triggers an immediate review, and you may be up for 1 year to reaccredit. If you are kind of on probation, if you didn't quite meet some non-core criteria, you get 1 year of probation, so that might also trigger an earlier review. But for the most part, it's every 2 years. Yes?
When did the level centers start? Like when was it created?
So that goes back to those first criteria in the 90s. That was the terminology we used, which really was built on kind of a broader sort of public health terminology. Level 1 is your primary care provider. Level 2 is your general neurology in the community or community hospital. Level 3 then becomes a specialized epileptologist and so allied groups with that. So it's a bit of kind of a time capsule of how the language was at that time. It's not a common differentiation.
It wasn't until very recently that I even heard about that it was around, so I thought, wow, that's awesome that there's something like that available now.
Yeah. We are, with the revision of the guidelines, one of the things that we're doing over the coming year is asking the question, is this the right way to describe epilepsy centers, or is it too constraining? What if you're a fantastic center that has deep, deep resources, but you don't do epilepsy surgery? Are we sort of diminishing the amount of recognition in some sense that you should get because you may be very, very good at something, but you don't do epilepsy surgery? Is epilepsy surgery the only metric to say, you know, what is a level 4, which sounds higher or better than a level 3? When that's not necessarily true. You could be very, very good at all the medical management of epilepsy, which is far and away the biggest part of epilepsy care.
Yeah.
And yet you would be a level 3 to another center that might do a few surgeries over the course of a year, but have much less of the medical, and that they would be a level 4. So there are some injustices built into this system, and we're trying to figure out what's the right way to deal with that. And most of all, the perspective that we take, that we try to really be thoughtful about, is what is the assurance we're giving a patient as they walk into the center and they see this accreditation level on the door? What can they reasonably conclude from that? And that's where that making sure that the basic levels are being met and that they're satisfactory.
Yeah.
Other questions? And I have a microphone here if anybody has a question. All of you, yes, go ahead.
When is the right time to seek an epilepsy center over, the regular?
So I actually left that slide out because I didn't want to get too far in the weeds, but it's a good question. So generally your first point of contact is going to be a pediatrician, or they may refer you to a neurologist, depending on where you are in the country and your access to specialists. In general, they'll make a first pass at treating seizures, But if you see that the seizures are not controlled after a few months, 2 or 3 months, that's, at that point, you really should be thinking of escalating. Now, certainly if you were the primary care doctor, going to a neurologist. If you're with a neurologist, going to an epilepsy center.
Yeah, he has the neurologist since birth. Yeah, so I think he needs a center. Yeah.
So that's the function of epilepsy centers. We exist to treat the patients who are not easily controlled on the first
He's
try.
on 6 seizure meds twice a day. He's still not controlled.
Yeah.
So,
And sometimes the role is to look at things in addition to medicines, beyond medicines, such as devices or surgeries.
He has
and
those.
things.
and they have stuff. He's got the VNS and the corpus callosum. That's why we're here trying to look for other options.
Sure.
Yeah, because we're from Indianapolis, so there's not too many. There's not an epilepsy center that I know of in Indianapolis. Because his developmental pediatrician told me to look at epilepsy centers
Right.
for
So,
clinical trials.
so you can go to that NAEC website,
Okay.
and if you Google NAEC epilepsy,
Okay.
there's a page where you can put in your zip code, and it will show you all the centers in Indiana, as well as a state that's close to you, that you're,
Okay.
you know, it's feasible.
Thank you.
Pleasure. Other questions? Yeah.
I saw your previous slides, it doesn't list dietitians as one of the providers that are required.
Doesn't listen.
Dietitians?
Dietitians.
As one of like the conditions to qualifying for a level 3 or a level 4, is that something that you would be considering, especially because now the diet is part of the treatment option?
Yes. And the answer is yes, and the guideline revision addresses that.
I know
Yeah.
you're late, but is it for only pediatric or older?
So both. The NAC recognizes 2 demographics. There's adult epilepsy centers, that's the larger part of the membership, and then there's pediatric. There's, I think if I remember the slide, there's 50 pediatric centers. There's about 78 pediatric and adult centers that are currently in the process of dividing into adult or pediatric or both. So that number that 50 will go up some as the adult pediatric classification splits up.
And there are centers that only focus on epilepsy.
Yes. So that is the whole purpose of these centers, is to focus on epilepsy and all the things that happen with epilepsy. So often there's behavior, mood, things like that can travel with epilepsy. And these centers try to have resources to deal with that too.
Do they have emergency rooms?
Most of, not all of our centers, I'd have to look specifically, are based in hospital, because one of the core requirements is that they have epilepsy monitoring units. This actually grew up around the epilepsy monitoring unit. I would have to say the vast majority, if not all, of those epilepsy monitoring units are in referral hospitals, you know, sort of tertiary care level hospitals that have emergency rooms. And I would be surprised if they weren't. But once you go to some of the smaller, least populated states, there's a little bit more of a hybrid model. I think they have emergency rooms, but I don't know if all 254 do. Certainly more than 250.
Well, I'm here in California and my son is 18.
Yeah.
And so he is now going to be going, not anytime soon, like in the next couple of years, they're going to be transferring him then to an adult stage. He's not in the children's hospital anymore, so I'm in the realm of looking for what my son is going to be going to next.
Yeah, it's a big transition. It's something that's kind of very variable across centers. Some centers really do it very thoughtfully, and some centers kind of leave families to navigate it more for themselves. And that tends to be the more common case, but it is a big transition. And done well, it can be really constructive and help the person sort of take on more of those adult
Yeah.
patient roles. Yeah.
My son doesn't only deal with epilepsy, he has feeding tube, he has scoliosis, he has other issues, so I think, to me, I need a big hospital, like Children's Hospital, to take care of him, but if there's another center, like, that can deal with his epilepsy. He's on 6 medications right now.
Two questions.
Sure.
First one, in my state, I see we have two places. One of them says it's a pediatric epilepsy program. It says applicant member. Are they in the process of becoming a center? Is that what that means?
Yes.
Okay. Then the other one, you had mentioned earlier that they're going to separate the adult and pediatric to be two separate. What's the plan for if one or the other needs to transition to a different facility that's going to treat? Is there going to be referral programs, or are they
So
going to do that?
sometimes what happens when we have these joint centers is that one center is meeting the criteria for level 4, and maybe the adult or the ped side meets a level 4, but the other one would meet the criteria for level 3. And one of the things that you'll see is that among the criteria, a level 3 has to have a referral relationship to a level 4. And that's the idea being that no matter what door you walk through, you should have access as a patient to all of the services that are appropriate. So that referral relationship is a requirement. For the most part, those centers can refer, if you want to look at epilepsy surgery, from your level 3 peds, for instance, to a level 4 adult if they do those surgeries. So the referral may be internal.
So they can stay in the same facility.
Yeah. Now, it's important, depending on the needs of a particular patient, to really, not every center does everything. And it's important to kind of make sure that what is needed falls in the skill set of the team there. Within that kind of group of level 4 centers, there's a lot of diversity and expertise, and particularly as you get into pediatric surgeries, there are very specialized surgeries that apply to pediatrics that are not common in adult centers. So those would be important things to try to learn about.
We've had to have surgery for our son. So that's the question I was wondering about. To separate those two is going to be referral for pediatricians to go to another pediatric center. Closest one to us would be Cincinnati.
Right, and Cincinnati has a lot of great
Yeah.
resources.
So if we would be able to just get a referral to go there instead of just showing up on your doorstep.
Well, you can also self-refer. You can call, make an appointment for most of these centers. You don't need to be sent by your current doctor.
Okay.
And if you go to that NAEC website, there'll be a phone number there that you can call to just learn more. That's really just exploring.
Does it update the information on the Indian hospitals or centers that are going to be?
There's usually a once-a-year update. The accreditation process closes. Our hospitals have to have all their data in by the end of January. Then that data gets kind of worked through, and by usually about April, there's everybody's accreditation determination is sent out.
Okay.
Other questions?
So did you say that one hospital might not do what another hospital does? So in that, if you're connected to one hospital, are all the hospitals connected that they know what's going on? Like if you're at this hospital, they can open up their record and they see what's going on in his case?
Generally, no. Generally, no. Hospital records don't cross hospital systems very well. That's one of the big gaps in medicine, broadly speaking, not just epilepsy care. Usually within a hospital network, if you're within a particular hospital system, they may share a medical record and be able to share. But once you cross that boundary, then even simple things can become very, very challenging. Being an advocate for your child collecting copies of records, keeping that as things go, as time passes, so you have your own record. Shouldn't be what we ask of families, but as being pragmatic, that's a good skill set to develop. Yeah. All right. Any other questions? Thank you all for your attention, and Brad and Candy Levy, who organized this kind of wonderful event. Really indebted to them for the opportunity.